how this works.
Hey guys.
Hey.
So we'll just wait a few more minutes to see who shows up. I'm recording this regardless, so someone can't come, no big deal, you know?
Okay.
So you can keep talking if you want. It's fine.
I think she was talking to somebody else.
Oh, okay. I thought you guys were talking.
No, I was here by myself. You guys both just actually joined.
Oh, okay.
Yeah.
So just great timing, huh?
Yeah, definitely. For a second, I was wondering if I joined the right Zoom.
No, you're fine. All right. Let me think here. See if I can write something on here. Hey, Mira. I guess that stuff doesn't matter. All right, well, it's 2 now, so I'm just gonna go ahead and get started. And then if people join, they join. If they don't, they don't. Okay, so on our upcoming test, we do have one whopping question on acid base. So since we don't really like go over it per se, I just want to make sure that you guys remember how to look at those. So if we had a question and it just gave you, the numbers, like the pH and the PaCO2 and the HCO3, would you be able to figure out what kind of acid-base problem it is? Do you guys remember this stuff very much?
Yeah.
All right, let's try one. I put, your stuff up here so you could see it. Let's say, okay, so our pH, it's hard for me to draw with this thing, is 7.58. The PaCO2 is 38.
Wait, these are the numbers from where?
I'm just giving you a problem to do. H
Oh, okay.
is 29. So if this was your problem right here, what kind of acid-base problem is that? Tell me which one of the four.
I think metabolic alkalosis. Is it metabolic alkalosis?
What's everyone else think? I just want to give everyone a chance to look at it. I know some people are quicker than others at doing it, so. You guys agree? So anyway, since no one's talking, so when you're looking at these problems, just to review, you look at your pH first, right? So it's 7.58. So then look up here, here's our normal values, and that falls high, right? So it means it's base, right? It's an alkalotic problem. Then you look at your other two things. So our CO2 is 38, so that's within normal limits, because look at our value here, right? So we know it's not a respiratory problem. And then our HCO3 is 29, which is high. It's out of the reference range. So yes, it is a metabolic alkalosis. Make sense? Let's try another one. If we did 7.48 for our pH, and our PaCO2 is 28. And the HCO3 is 23. What's that one?
It's a metabolic acidosis.
It's respiratory alkalosis.
Yes, it's respiratory alkalosis. So this is why. So again, look at your pH, 7.48. It's above, right? Just like the other one was. So we know it's an alkalotic problem. Then you look at your other two things. So your CO2 says 28. So it's not within this range. So it's outside of that. So we know it's a respiratory problem because that's what's abnormal. Then 23 is within this. So we know it's not that. So it's respiratory alkalosis. Do you want one more?
Can you just explain to me how I can figure out whether it's respiratory or metabolic?
So whichever one of these two things is not within the right range, that's what you're going with.
Okay, so the CO2 obviously is respiratory, and then the CO3 is metabolic.
Correct.
Okay.
Does that make sense?
Yeah.
Okay. I'll give you one more just for the heck of it. We'll do that. Now, the question that you have on the test is like this. So it's not going to be like, oh, is this compensating or not? It's just going to be, hey, is this respiratory or metabolic alkalosis or acidosis? Okay. All right. So this other one, let's say our pH is 6.98. And then our PaCO2 is 30. And our HCO3 is 18. Oh, that one's kind of hard. Here, let me change one of these. Let's say this is 23. So what would that be?
Respiratory acidosis.
Yes, respiratory acidosis. So what you'll have on the test will be just like this. It'll be real nice and simple, nothing crazy.
And so, like, I assume, do we learn the harder ones later on?
Well, what makes these things hard is when you do the compensating and not compensating. That's what's the difficult thing.
Okay.
So again, when you do NCLEX isn't even going to ask you that. They'll just be real simple like this.
Right.
Okay. All right, so that takes care of that one. Let me erase all of this for a second. All right, do you guys remember talking about electrolyte problems? I don't know how much of that you remember. What I was wondering is, do you remember your values? So like if I said, what's a normal sodium level? What would you say?
135 to 145.
Okay. And then if I said, what's a normal potassium level? What would you say?
3.5 to 5.0.
Okay. And then how about calcium?
I think that one was 8.5 to 10.5.
Okay.
But then in some places it's 6. So that's the question I had to ask you. I had that question.
So say that one more time, 8.5
So
to 10.5.
it's 8.5 to 10.5, but in I think the book it was either 8.6 to 10 point something
Yeah.
like that.
So
It's
depending on what book you're in, it's going to be slightly different sometimes. But when I was trying to get you guys to learn this stuff, it's just
it was
easier to remember
8.5.
it in the fives, you know?
Yeah.
So you're not that far off. So I mean, it's fine. I would just continue to know it the way that you know it. Because it's not like you're going to get something wrong from that. Okay? All right, so that was calcium. Then how about magnesium?
That is 1.5 to, was it? Oh, I forgot that one.
1.5 to 2.5.
Okay. How about phosphorus?
2.4 to 4.4. Or 2.5 to 4.5.
Yeah. I'm trying to think, did we do any other ones or was that it? Did I tell you chloride?
It's 96 to 106.
Okay. I think that's all of them, right? Am I forgetting any? I think that was it. So anyway, on this test, there's going to be certain things about electrolytes where you're going to have to know what a normal level is to be able to pick out if it's, too high or too low. And then there's certain other things that you need to remember about these electrolytes. So like when we're talking about sodium, if someone has a messed up sodium, whether it's too high or too low, if they also present with being confused, what would you assess first on them?
You said if their sodium is low.
Yeah, it doesn't matter if it's low or high. You just know that it's abnormal. And then you also know that they're confused. So what would you assess on them first? Like if you're doing an assessment, what would you want to look at first?
Maybe their neurologic status.
Yes. So there's something similar to that on this is what I'm telling you. So like, I forget how exactly it's worded, but it's something about them, like they're starting to get confused or their mental status has changed or something like that. So yes, it's trying to get you to say, hey, I need to look at their neurostatus, something's going on there. So another thing, with sodium, when you're looking at sodium, you always think neuro anyway, right? So that kind of all goes together. So sodium, whether it's low or high, you think neuro problems. What do you think of when you think of potassium?
Their heart.
Yeah. So like, if you have a low potassium or a high potassium, you can have heart issues. You can have arrhythmias. So that's definitely something to remember there. Let me think, what else is on there?
Okay, wait. For that one, I have a question.
Yeah.
So, because on the study guide you put the cardiac arrhythmias, it was saying which electrolyte we should focus on.
Mhm.
So for that one, is it going to be like potassium? Because I know
Yeah.
like
Yes,
okay.
it's potassium. Yeah, there's a ton of different electrolytes that can be off that can cause arrhythmias. You're correct with that. But for the most part, when you're just looking at a whole at your electrolytes, the thing I want you to associate that with is potassium.
Okay.
Okay, so do you remember also when we talked about calcium and phosphorus? What's the relationship between those two?
When calcium is actually when the other one is low, calcium is high, and so it kind of intertwines.
Yes, so if calcium is high, phosphorus is low. If phosphorus is high, calcium's low. Okay, so they're like an inverse relationship. So remember that, because that's also important on here. And then going back to the acid-base stuff, like there's only one question where you're going to have to figure out an acid-base, problem. But then there's another question that has to do with your electrolytes and what electrolyte is associated with an acid-base problem. How would you answer that? I don't know if you guys remember that.
Sodium. Is it sodium?
No, it's potassium.
It's potassium.
Yes. So remember when we talked about metabolic and respiratory acidosis? Anytime you see acidosis, you're going to think high potassium. Anytime you see alkalosis, whether it's respiratory or metabolic, you're going to think low potassium. So that's also something you need to remember.
Wait, can you repeat that? I'm sorry.
Yeah. No, that's fine. So if you see in a problem something about metabolic acidosis or respiratory acidosis, acidosis is the key, okay? So if you
Yeah.
see that, you're going to say high potassium. It's associated with that. Anytime you have an acidosis, you also have a high potassium.
Okay.
And then it would be the opposite for alkalosis. So every time you see that, you're going to say low potassium.
Got it.
Okay, I'm not trying to take us back because I just went blank for a minute.
That's
Sorry.
okay. You're all right.
So in order, when we are doing what we started doing before, which one did you say determines whether it is respiratory and metabolic? Were you saying the PaCO2 is what determines whether it's respiratory?
So here, just let me just say it again. So when you're looking at those acid-base problems, you first look at your pH, right? And you see, okay, does it fall on the high side or the low side? So if it's high, it's going to be like, alkalotic or, metabolic problem, right? If it's low, it's going to be an acid problem. So that's like the last part of your answer, right? So is it acidosis or alkalosis? So then when you're trying to figure out if it's respiratory or metabolic, that's when you look at those other two values. So you have to look at both of them. So you look at the PaCO2 and you also look at the HCO3. Whichever one of those two things is outside of the reference range, that's what determines if it's respiratory or metabolic.
Okay,
Okay,
got it.
all right. Trying to think what else I need to hit with you guys. Okay, I think we kind of talked about like the different fluid compartments before, right? Did we talk about like interstitial fluid and extracellular fluid and all that kind of stuff and where it goes in your body? So there's something on the test having to do with third spacing. What is third spacing? What does that mean?
Third spacing is when there is fluid outside is it the internal organ?
So basically, fluid is somewhere where it shouldn't be. Okay,
Yeah.
so it's not normally in the place where you're finding it. So, like, for example, people with liver failure or people who have, problems with their liver, they're going to get ascites, right? And ascites is that collection of fluid inside their abdominal cavity where it shouldn't be. So it makes them look like they're pregnant, I guess that's kind of the easiest way to describe it. Just say that it's a collection of fluid in a place where it normally should not be. When you guys are assessing someone and you're looking at skin turgor, what's important to know about assessing for skin turgor?
If the skin goes back within 20 to 30 seconds or not.
Mm-hmm.
Okay, so what's a normal skin turgor? What's it supposed to do?
Supposed to bounce back. So
Okay.
when you touch the skin, it's supposed to fall right back.
Okay.
Mm-hmm.
If it
Figure out
sticks
what
in the same place, what happens? What's that mean?
You're
It means
dehydrated.
they dehydrate
Yeah.
it.
Yes.
Dehydrated.
There's also a question about skin turgor on there and just assessing it. Okay, so you need to know that. Back when we talked about some of that skin stuff, remember we talked about primary, secondary, and tertiary healing, right? So we said primary intention healing, like you might have, like say this is an abdominal incision right here, and you have, I don't know, sutures or staples all the way down your incision. So that would be primary intention healing because this is well approximated, it's closed up, but you also have like sutures or staples, keeping it closed. So it's clean, it doesn't look infected, it's, no issues. And usually after you get your sutures or staples out, you can barely tell you had anything there. You might have a little bit of scarring, but not much of anything, right? So that's primary intention. Secondary intention would be like, trying to think what to draw here. Say someone has a pressure ulcer that's really bad. This is going to be a stupid drawing, sorry. All right, so this is someone's behind, and this is their sacrum, okay? So they've got this is their wound right here, which I'm not doing a very good job. Okay, so because this is so deep, this is not something that you can just sew up like you did this one. So this is something that has to heal from the inside out, so, like it's like you have a crater, there. So it's very deep. So because of that, you're waiting for this skin tissue to kind of fill in here, like your granulation tissue, and then it'll heal like that. So this you definitely will have a scar from, and you can't just close it up like you did this one. And then remember, tertiary healing is totally different. It's the same thing as secondary in a way because it's very deep. You might have like a big crater like that, but it's infected. That's the difference. So what's in here is infected, like this could be gangrene or something. So maybe they came in and they did surgery or something to clean all that out, but they didn't want to close it up because they want all of that infection to like drain out. And they bring you back a couple of days later to close it up. Do you guys remember that? Yes?
Yeah.
Okay, so that's that concept. And then tell me about, like if you had to pick out what was a unstageable wound, how would you describe that? What's that?
Thing where you could see the
Eschar.
bone, right?
You have eschar, okay. And what'd you say, Krishna?
When you can see like almost through the bone, or almost to the bone, I should say.
That's
Well,
not unstable.
Not unstageable. No. Unstageable, so it means that it has some kind of black covering over it. So you can't tell how deep it is or anything. So you can't stage it. That's why they call it unstageable. It has that eschar formed over top of it.
Got it.
The
Would
kind-
deep tissue fall into that too?
So a deep tissue injury looks like a bruise. Just think of bruising, and that's what that is. So like you could have a real dark purple color to it, or like a bluish color or whatever. It's gonna look kind of like that. So it doesn't look like there's an opening or anything. It's just that bruised look to it.
Yeah, would that be unstageable too?
No, that's, you just say deep tissue injury for that. All right, so the one that you were describing, Krishna, you said you could see muscle and bone. So what stage would that be, everyone?
Stage
Fourth
3.
stage.
Isn't that stage 4?
If you
Stage
say
4.
muscle and bone is stage 4.
It's stage 4.
Mm.
Yes, so what's the difference between a 3 and a 4?
I think the difference is the bone. If you see the bone.
Okay,
The
so
3 has subcutaneous fat.
yeah, it's the thickness. So when you're reading about this, like if you have a question that talks about this, it's how thick it is, like how deep it is. So the deeper you go, you know, you get past the subcutaneous fat and you get towards the bone, that's really deep, right? Compared to stage 3, if you just get into the subcutaneous fat, it's not as deep. So it
Mhm,
still seems bad, but it's still, you know, not quite as deep.
mhm.
So that's kind of what you need to pay attention to in those types of questions, just like how thick it is. Let me see what else. My other thing. Okay, so we also talked about, well, we briefly said something about autoimmune disorders. What's an autoimmune disorder? Do you guys know?
When your body attacks its own cells.
Okay, so it's like your body sees something that's foreign and it doesn't understand what's going on. So it's like, oh, this is bad. I'm going to attack that and try and get rid of it. So there's quite a few different disease processes that are like that. And you guys have a select all that apply question that wants you to be able to pick out which ones are autoimmune disorders. So can you name some?
Lupus.
Okay,
Myasthenia gravis.
okay.
It's a lot of autoimmune disorders.
There's quite a few, but I just want to make sure that there's not one that's on here that you're not going to be like, oh, that's autoimmune. I didn't know that. I
Mhm.
know in your book, there's like I think that there's like a table of some sort that lists them all. But so you guys understand, you already said lupus. Did you know rheumatoid arthritis is autoimmune, right?
Yeah,
Yeah.
What about Graves' disease? Is that autoimmune?
it is
Yeah.
hyperthyroidism.
What about multiple sclerosis?
Yes.
Yep, it's part of it.
What
Multiple
about
sclerosis.
celiac disease?
It is part of autoimmune disorder.
And then what about Hodgkin's lymphoma?
Whoa.
Mm,
Yes, that's, oh no, I don't even know what
I
that
don't
is.
think so.
Yeah, Hodgkin's lymphoma is not.
I don't think so. Yeah.
Yeah. So again, make sure you go in your book and look at that little table because it'll list them all. And that way you'll be like, oh yeah, I remember looking at that, you know?
Okay, so we'll be selecting the ones that are part of it.
Yes. Yes.
Mm.
So it's going to be something like which of the following diseases should you include in a talk about autoimmune disorders, you know? Something stupid like that.
What is Hemochromatosis. What is that?
Oh my God.
Hemochromatosis.
Is that something I put on your thing?
No, but it's in the table. It's part of it.
Oh,
Because for a minute when you said Hodgkin's, I was like, nah, I need to know what that H thing is anyways. Because it's also an autoimmune disease.
huh.
Yeah, unfortunately.
Well, let's look. So it is your body, it causes your body to absorb too much iron from your food that you eat.
Mm.
So you get excess iron that's stored inside your organs. Too much iron can lead to life-threatening problems, you know? So heart
Yeah.
problems, diabetes, whatever. So yeah, so hemochromatosis is autoimmune.
Okay.
So which one did you say wasn't part? I wasn't getting the word well.
Is a Hodgkin's lymphoma?
Yeah, Hodgkin's lymphoma is not an autoimmune disorder. That's a type of cancer. All right, let me think what else I want to go over real quick, and then we'll do my thing that I made for you. All right, so tell me what you guys remember about HIV and AIDS. What are some important things to remember about that?
Finish your ART drug completely. I mean, don't follow the course.
Yes. Okay.
Was it ensure that you're up to date on your vaccination, Hep B, flu, all the good stuff?
Yeah, so if you have someone who's newly diagnosed with HIV, if you wanted to do something prophylactically to help keep them well, you could have them get a flu shot, have them get all of those types of things, right? So tell me about the different stages of HIV.
I think the stage one, you can really tell the CD4 count is a little bit okay. And stage two is like less than 500, like maybe 200 to 499 or something. And then stage three is when it's like below 200.
Okay. So in that first stage, when you first get diagnosed, what kinds of symptoms might you have?
Flu-like symptoms?
Yes. So typically you don't have anything too significant to make you think that you have this, right? So people tend to go around and still do all of these crazy things that they normally do, and they're spreading it because they don't realize. So then once they do realize they have it, if you get on those antiretroviral meds right away and you take those, you probably are going to be fine for a while, you know? But then once you get to stage three, what puts you in stage three?
Environmental.
How do you progress to that?
When you have like untreated, when you're not taking your medications, right?
Well, I mean, yeah, I see what you're going with that, but that's not what I'm getting at. So the thing that you guys are forgetting with stage three, you have to have some type of opportunistic infection associated with your CD4 count as well. Okay.
That's like pneumonia.
Yeah. So you could have Kaposi sarcoma. You could have TB. You could have just a fungal infection. You know, whatever. So something sets you over the edge. Because your CD4 count is so low, you get that other infection, and it kind of puts you into full-blown AIDS then. Okay? But yes, you're correct about that CD4 count. At each stage, it gets lower and lower. So if you were like say you're a nurse practitioner and you're seeing HIV patients in your clinic, what kinds of testing would you do every time they come in to be seen by you? What type of test would you do?
Viral load.
you would do a viral load, right? What's the viral load tell you?
How much of the virus is in the patient's body?
Yeah. So the idea is if they take those antiretroviral meds like they're supposed to, and they're doing, you know, the things that they're supposed to be doing, then hopefully that viral load will be so little that you hardly will be able to detect it at all, right? That's what our goal would be, is to have maybe an undetectable viral load. When you're at that stage, that means that, you know, you're being treated with your meds, the virus is kind of, you know, under control in a way because it's so little of an amount in your system. So that means if you did go out and have sex with someone or something like that, that the chances of you passing it are going to be very minute now. Okay? So definitely know about that viral load. That's definitely important. Okay, so the stuff that we just talked about the other day in class, all that endocrine stuff, how are you feeling about that stuff?
We don't mind going over it.
You don't mind going over it? Okay, I'll say a few things real quick and then we'll do our other stuff. Okay.
Quick question.
Yeah.
So because I saw a question on the study guide that was talking about AIDS with social interaction. So that one will be false, or will it be true? Like it says, social interaction with others is not a priority. It's not a top priority when you are in the end
I didn't
stage.
know how to put that in the form of a question for you, so I just put a statement there.
Okay.
Okay. You'll see, when you see it, it should be obvious.
Uh-huh.
So in the question, this person, I think they're end stage, you know, AIDS, and people are wanting to come see them or something, and they just don't want to have anything to do with anyone.
Oh,
So it's kind of about that, okay? Because they're at the end of their disease process, they feel horrible, so they don't really want to be interacting with people. Okay? All right, so let's move on to this endocrine stuff for a second. So basically, on the test, I would say the thyroid stuff is a little bit more heavy than the Addison's and Cushing's stuff is. It's a little bit more heavier with the thyroid. So it does mention Graves' disease. What do you remember about Graves' disease?
It's a disease that pops up when you have hyperthyroidism,
Okay.
overactive thyroid.
Yeah, so it's a type of hyperthyroidism. And when we say hyperthyroidism, what are we talking about? What's going on?
It means you have increased T3 and T4 and decreased TSH.
Yes. Okay, so because we have these increased amounts of thyroid hormones, remember it has to do with our metabolism. So we're in this hypermetabolic state when this is going on. So signs and symptoms then associated with, you know, Graves or hyperthyroidism would be, you know, things that are speeding up your metabolism. Just think like that. So I don't know if you remember that picture I showed you in class the other day. So remember, one of the things is you have an intolerance to heat. So remember, he had that fan in front of him and he's just has sweat dripping off of him anyway. So no matter what he does, he's constantly hot, right? So that was one thing. Another thing had to do with weight. What does your weight do when you have a high metabolism?
Weight loss, because you're losing everything.
Yes, yes. And then what would your heart rate do?
I think it is rapid.
Yes, it's going to be high because, you know, we have this high metabolism. So high heart rate. What would your blood pressure do?
increase.
Increase. So high blood pressure. Remember, I don't know if you remember on the one side of the picture, I'm just thinking about the picture and talking. You remember on the one side of the picture, it talked about like some abdominal type things, you know, with bowels. What goes on with your bowels with this?
Diarrhea.
Yes, because again, your metabolism is set up so everything's just coming out quickly, right? What's your hair do?
It's long and thin. Not
Yeah,
long, but thin.
well, it's,
Straight.
yeah, it's, I guess you could say it's a little, I don't want to say healthier, but kind of compared to hypo, you know? Hypo is when you like start to get a receding hairline. It's like you're having hair loss with hypo. This, maybe you might have like brittle hair or something, but it's still there, you know? Now, one thing that you need to remember with Graves' disease, remember you have specific symptoms that you see, right? So for how you have like the bug eyes, what's that called?
Bulging or
There's a specific name for it.
Can you repeat what you said, please?
So we're talking about Graves' disease, and there's a couple of specific symptoms that go with that. So if someone has hyperthyroidism because of Graves' disease, they're going to have those bug eyes. What are those called? What do they call that?
The exophthalmos? Oh,
Yes. Which
it's
hard.
called what?
I think it's like exophthalmos. I can't pronounce it, but something.
It's hard to pronounce, but it's in your ATI book. So in that chapter about hyperthyroidism, there's a picture and it shows how to spell that word. Okay. The other thing associated with Graves' disease is that tibial myxedema, right? So that's like that waxy looking craziness of your skin on the front of your legs. So those are a couple things that are more specific to this. Okay, so we've talked about, you know, hey, this is a hypermetabolic state. We talked about signs and symptoms. We talked about what your labs would look like, because you just said high T3 and T4, low TSH. What else is there to know about hyperthyroidism? How would we treat this?
Anti-thyroid medication.
Okay, so if we did the anti-thyroid medication, what are the names of those two meds that we talked about?
Capsol and
Tramadol.
PTU.
Yes. Okay, I did tell you a few things about those, and I'm hoping you read more about them. Is there anything in particular that's important to know about those two medications? Do they take long to kick in when you start taking them?
Yes. I think for the PTU, the book says a couple weeks, like 2 to 6 weeks, but the
Yes.
meta something was, I think, longer.
Yes. So that's important. So there is a question about that. So if you were teaching someone that's new to taking these meds, that's something you want to tell them, right? Because if they think they're going to get relief right away, that's not the case. Now, something else I don't think I told you in class, but occasionally when someone has hyperthyroidism, they will also put them on a beta blocker because they have that high heart rate, and that will help some of their symptoms, because sometimes they'll feel like they have palpitations because of the high heart rate and it's uncomfortable for them. So the beta blocker would help keep that at bay and also help with their blood pressure a little bit. So remember, okay, other than those meds, what are some other things that we could do for hyperthyroidism?
The radioactive iodine therapy.
Did you guys read about that in the ATI book a little bit? I hope.
Not in the ATI.
What's wrong with you guys? I made sure you got those ATI books. They sent them to you in the mail. You should be looking at those. There's a reason we're giving you those. So tell me what you know about radioactive iodine. What do you guys remember about that?
It's like when you get that, you have to stay away from people.
Okay,
Use like a private toilet and stuff.
okay.
And also avoid being close to a pregnant woman and children for 7 days.
Definitely.
Don't handle, it says, don't prepare food for others, or handle things with your bare hands.
Okay. Do you get any weird side effects from it? Yeah, I don't know if you read anything about that.
Yeah, you might get like hypothyroidism, like side effects. So they might kick in while doing it.
What else though? Anything else?
Dryness and
Like they'll get dry throat.
Okay, what could you tell someone to do for that?
Take a sip of water.
Did it say anything in particular in the book to like,
It says take a sip of water or ice chips or salt or something.
it did
I
say
think
something
that's,
about salt?
yeah, salt, yeah.
So there's an option about something about if your mouth is irritated and dry from this medicine, you can gargle with a mixture of salt and baking soda several times a day.
Yeah.
So that's important. Okay, so we've mentioned the meds, we mentioned the radioactive iodine. What's the third thing we could do for hyperthyroidism?
Surgery, take it away.
Yes, remember that's called a thyroidectomy, right?
Thyroid, yeah.
So when we take it out, anterior incision on the neck right here, right? Usually it's really tiny, but things we're worried about would be swelling of our airway, right? Because it's right here. So things that we want to tell people afterwards is to really watch how they move their neck around, right? We don't want to have a hyperextended neck. If we have to transfer them somewhere, like from a bed to a cart, we have to like really support their neck as we're moving them. Usually when they come back from surgery, if you're worried about that swelling that they get there, usually you put an ice bag over the incision for a while to try and help keep that swelling down. We already talked in class about how you don't want to keep them flat. You always want to keep them kind of up in the bed a little bit, also because of their airway. What are some other things we're worried about other than that?
We are worried about, was it decreased calcium in their
Yes,
blood, whatever?
yes. So we're worried about decreased calcium. So they always will draw a level, you know, shortly after that surgery to make sure that it's not too low. So if it is, you can replace it. So the thing is, which I don't know if I explained this to you in class or not, but so you know how your thyroid's right here in your neck, it's like a butterfly shaped organ. On top of your thyroid, you have parathyroid glands. There's 4 of those, and they're really tiny. So it's easy when you take the thyroid out of someone to accidentally mess with these parathyroid glands because they're almost right on top of this. So if you damaged one or you took one out accidentally with the thyroid gland, then they could be low in calcium because your parathyroid gland actually makes your calcium. Okay, so that's kind of the reasoning on why you would be low. Do you remember those 2 signs that we talked about that you could test people to see if they had a low calcium?
Trophtek and Troisius signs.
Which one's which?
The Troisius was, if you move your hands between, like, I don't know if I should say the jugular muscle or whatever, like right beside the cheek area below.
So look at my camera here. So see my earlobe, right? So there's my jaw. So you follow the person's jaw up almost like right perpendicular to the ear, and it's like right here is where you're going to be tapping at. Okay, so that's chopsticks. So if you tap, they might like curl their mouth up or do something like that with their mouth. Now, what is Trousseau's?
Using the blood pressure cuff and leaving it there for a couple minutes or so. And if they squeeze your hands or something like that, it means it's positive that they have low calcium.
Well, they don't squeeze your hand or anything, but they do something with their hand as a result. So their hand kind of like twists funny. And I don't know, it's in the picture that I showed you.
Yeah.
I don't know if they have a picture in your book or not. Hopefully they do. But yeah, so that's another thing that you could do to see if maybe their calcium is low. So that's always super important to check for after thyroid surgery. What's a couple other things that I mentioned that you'd be worried about?
Thyroid storm.
Thyroid storm, yes. So again, when you take the thyroid out, you could see why easily maybe some of those thyroid hormones would squirt into the bloodstream inadvertently and maybe cause this, right? So we said with thyroid storm, all of your symptoms of hyperthyroidism would be to the extreme now. So as a result, you're just treating each one of those symptoms. So if it's the high temperature, I'm treating that. If it's the high heart rate, I'm treating that. You know, whatever it is, you're treating your symptoms. But you also have to remember to treat that thyroid. So you would be giving some of those anti-thyroid meds IV to get that under control for this person as well. So definitely a medical emergency. And then do you remember we talked about you want to get people talking after surgery because you're worried about their vocal cords, like you may have had damage there. You could have that. And then also we talked about bleeding. So typically you'll have just a little incision right here with a dressing over it. And over that first 24 hours, you should not see a ton of drainage. It should be very scant. So if you see a lot of drainage there, that's a huge problem. Okay, so those are things to remember about that. What about hypothyroidism? So first of all, hypothyroidism would mean that you don't have enough thyroid hormones in your system, right? And do you remember when we talked about where those came from? Where do we make thyroid hormones?
Iodine?
What's that?
Like iodine?
Well, iodine helps us make them, but where do we make them at? I didn't hear that. What was that? No one's saying anything.
Like maybe you should rephrase. You said where do we make them at?
Where do we make them at? Where are they coming from?
I mean the thyroid glands. Is it coming from the thyroid glands?
We make them with, is it the hypothalamus?
Yes, that's what
Okay.
I'm looking for.
Oh.
Okay, so with low thyroid, hypothyroidism. Remember we said that older women are more at risk for this because some of the symptoms that they get tend to look a lot like normal aging, so they get misdiagnosed and they don't get diagnosed with it very quickly. So older women definitely seem to have this more than, compared to men. What are some causes of hypothyroidism? What's probably one of the #1 causes?
Malnutrition.
That's not what I'm looking for. Remember it has that weird Japanese name to it?
Hashimoto.
Yeah. Hashimoto's thyroiditis. That's probably one of the #1 causes why people get hypothyroidism. And you could also, just have it because you had your thyroid taken out because maybe you had hyperthyroidism at one point. So the thing is, when you have hypothyroidism, you are treated with Synthroid or levothyroxine, and you have to be on that for the rest of your life. So they need to make sure they understand that. What do we know about that drug? how quick does that kick in?
I have a quick question before we talk about this drug. So you can basically get both. You could get hyperthyroidism and hypothyroidism in your lifetime.
Yeah. Yep. So like if you had hyper and they ended up taking your thyroid out, you're now considered hypothyroidism. You're considered to be having hypo. And like if you had hypo and like say you didn't get your thyroid taken out, but you just had hypothyroidism, that's why you always get your levels drawn every so often, you know, to see where you're at. Because if you take too much of your thyroid hormone, it can make you hyperthyroid.
Oh my God.
All right, so going back to this, so we just said Synthroid was our thing to take. You take it daily for the rest of your life. You can't just go off of it. It takes it a while to kick in. So that's something that people should always know. Usually you take it in the morning. You don't take it at night or anything like that. Usually it's, you know, before breakfast, before you eat. Trying to think what else with this. Tell me some signs and symptoms with hypothyroid. What would be some things that we would see with hypothyroid? If you didn't have a high metabolism, you have a low metabolism, what would you look like?
You'll be overweight.
Okay. What else?
Bradycardia, like everything is kind of like slowed down.
Yeah, so maybe some bradycardia.
Hypertension.
Okay. What would be going on with your bowels?
Constipation.
Constipation. And then remember I said,
Intolerance to cold.
yeah. And remember I said about the hair, they could have a receding hairline. So in that one picture that I showed you, that guy had a receding hairline. So those are some of the things just to remember, you know, for that, in case you would get a question like that. What your labs look like with this one? So if we have hypothyroidism, what's our TSH going to look like?
That would increase.
Okay. And then your T3 and T4 would be decreased, right?
Decrease, yeah. Receding hairline. Yeah.
Okay. And then what's the name? You don't have a question about this on your test, but I'm just asking you to see if you remember. What's the name of the disorder that you can have if you maybe don't know that you have hypothyroidism, or maybe
Myxedema coma.
Yes. So again, everything goes to the extreme. It's a definite medical emergency as well. And you can actually, you know, go into respiratory distress, your heart can stop, all kinds of craziness. So it's a big deal as well. And as you're treating all of the symptoms for this, you should also treat this, you know, with Synthroid, Synthroid.
So the myxedema, is it like just associated with the hyperthyroidism and hypothyroidism?
Say that one more time, I didn't hear that.
Is it associated with hyperthyroidism and hypothyroidism? The myxedema.
Yeah, so I know you're thinking when we talked about Graves' disease with hyper, we talked about pretibial myxedema. That's what you're thinking of.
Oh, okay.
But no, so myxedema coma is always going to be hypothyroid.
Okay.
Okay. All right, so that's kind of the thyroid stuff. And then with Cushing's and Addison's, this, to me, those are a little bit harder to remember. But again, like I said, you don't have a ton on your test about these. There's just a couple of things. So what's the hormones that we're looking at with Addison's and Cushing's?
We're looking at cortisol and sometimes aldosterone.
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 Yeah. So
Spironolactone.
more so cortisol than anything, right?
Yeah.
So we said, you know, the hormones that we deal with these two things, they're mineralocorticoids, glucocorticoids, and those sex hormones. But when we see a disorder, you know, like Addison's, you're going to have too little of the hormone. And so it's specifically the cortisol that's low. Sometimes also the aldosterone, but all the time it's going to be the cortisol.
Mhm.
So with this one, some of the things that you see associated with it, you would see things like that hyperpigmentation of the skin. So it's going to look like a bronzy looking skin. You would see stuff like they might crave salt, you know, because they're going to have a low sodium level. So they have this salt craving. They could have low blood sugar. They could also have low blood pressure where they get to the point where they pass out or get dizzy. And then, you know, there's other things associated with it as well. Like sometimes they'll have abdominal things going on where they'll have nausea, vomiting. They'll actually have weight loss associated with this. And there's a few others, but that's the basic ones for Addison's. So when you're thinking about labs that are abnormal, you would see a low cortisol level, a low sodium level, a high potassium level, a low glucose, and probably a high calcium as well. All right, so with Addison's disease, you are going to be taking replacement hormones basically for what you're low in. So if you were just low in cortisol, you're going to be taking what?
Hydrocortisol
Yes.
injections.
Yes. If you also have a low aldosterone level, what are you going to be taking?
Is it spur?
It's fludrocortisone. I think there's another name for it. I can't think of it. Let me see if I can find it in here. Fludrocortisone is the name, though. Yeah, of course, the ATI book doesn't have the other name in it, though.
Is it prednisone, or is that what you're talking about?
No, it's not prednisone. If we're talking prednisone, that's going to be your replacement for cortisol because that's a glucocorticoid. When we're talking aldosterone, it's called fludrocortisone. That's the big name for it. And then there's a smaller name that I just can't think of it at the moment. All right, there is an extreme with this as well. So we said someone could go into Addisonian crisis with this, and all of your signs and symptoms would be to the extreme as well. So again, this person would, you know, you're treating all of their symptoms, and then you're also giving them these glucocorticoids, you know, to treat their problem. All right, what's the weird thing about Addison's disease? What do people have to do in response to stressful times?
Continue taking that medication.
So they may have to up their dose of their medication. So stress, you know, will cause your symptoms to be worse. So like if you know you're going to have surgery sometime soon, or you know that you're sick at the time, like you just have a cold or something, there's extra stress to your body from those things, then you're going to want to increase your dose. These guys also take salt tablets. And that, you know, so to me, this is kind of a weird disease because what disease do you know where people actually kind of like can up their dose whenever they want to? It's just weird, right? So that's kind of something specific to Addison's disease. All right, then with Cushing's. Cushing's is going to be the opposite of this. So before we didn't have enough of those hormones. Now we have too much. So we're making too much cortisol, maybe too much aldosterone, so now we're having other issues. So this person typically looks really um, overweight and unhealthy. So their middle is big. They have really small arms and legs. So their small arms and legs are telling you they have muscle wasting going on. They're going to be at high risk for osteoporosis related fractures. They also have a low immune system, so they can have a hard time healing different things. So like sometimes on those pictures, like I showed you before, they might show like an area on their skin that looks like it's not healed up because of that. You could see striation marks on their abdomen because they're so big around the abdomen. Their face is going to look round like a moon face.
Yeah.
You can see like reddened cheeks, sometimes acne, and then that buffalo hump right here on their back. So remember, just a little bit of a hump there between your shoulder blades. What else? Is that it? Am I forgetting anything?
I think so.
Oh,
I think
and
that's it.
with this one too, sometimes like because you're producing so much more of these hormones, sometimes the sex hormones also are out of whack. So you could see like that facial hair on women and like weird stuff like that going on too. So that's another thing that you could see. All right, so with Cushing's, typically you have it because maybe you have a tumor or something weird going on that's causing you to secrete all of these hormones like this. So if they suspected this in someone, they would do testing to see what caused it, to see if they could figure it out, because your treatment is going to kind of depend on what's caused it. So if it's because I had a tumor, or if I have cancer or something like that, maybe I'm getting radiation or chemo to fix it. Or if they think they can go in and like take it out surgically without an issue, then they're going to do that. But they also have medications too that you can take, right? So what did we say that you can take for this? Ketoconazole is a medication that you can take for this. So this is an adrenocorticosteroid inhibitor. There's also another one.
Again?
What's that?
Ketoconazole.
Ketoconazole. There's also another one that your ATI book mentions that you could take a look at. I think it's called Mitotane. All right, so I did make a game to do real quick, so I'm gonna pull that up real fast. Get that up here.
Should we join?
Hold on. Yes, you should join. Let me see if I might have to sign in again or something. It's acting weird. Hold on. Oh, this. Let me try and join again. Hold on. I had it pulled up for so long, I think it kicked me out. Oh, there we go. Okay, there's the number that you need to put in to join. Anyone else gonna sign in?
Yeah, I'm going to. Okay. Sorry, it was taking a while.
Lisa, you having issues?
I'm in.
You're in now? Okay.
Yeah.
Anyone else, or can I go ahead and start? All right, I'm gonna start. Okay, fluid developing in a place where it normally shouldn't be is
It's third spacing. Sorry, I'll be heading out, so I'm not on there.
that's okay.
I forgot.
At least someone's listening, right?
Let me mute it.
What medication would you give to a patient with Graves' disease? ETU. The cat was so funny. Did you see the face? Okay. A common sign of Graves' disease includes blank or protrusion of the eyes. There it is. So that's how you spell it, Gloria. Exophthalmos, I guess.
Yep.
What could be the cause of hypothyroidism?
Hush.
Hashimoto's thyroiditis. Okay. The lab tests of hypothyroidism will show what? Okay, so increased TSH, decreased T3 and T4. Okay, here's a respiratory acidosis question. So it gives you the stuff, see if you can figure out which one is respiratory acidosis. It's pretty good. So it's this one, 7.25, PaCO2 is 58. Okay. What's the goal for the viral load? Okay, he just told you. So to be undetectable in the blood, that's what we would want to see. All right, one reason that anaphylaxis is dangerous is that it causes swelling that interferes with breathing. Boy, did you see that guy's lips? My goodness. Okay, first aid for someone with anaphylaxis includes what? Keep calm, call 911, use the EpiPen if they have one. Okay, a patient undergoes a thyroidectomy. What lab would the nurse monitor closely? Calcium. Always the calcium. Okay, prior to a thyroidectomy, the patient should be taught to do which of the following? So how to support the neck when moving?
I like these questions.
Okay, treatment of Addison's disease includes which of the following? Okay, so hydrocortisone and fludrocortisone, because remember this part, the fludrocortisone is for that aldosterone problem. I know, too bad our questions aren't like this on our test, right?
Yeah.
Okay, Addison's disease. It's the adrenal gland hypofunction, so it's not functioning like it should. So you have that low amount of those hormones. Okay, Cushing syndrome, what's that associated with here? All right, so it's I can't say aldrinism, hypersecretion of cortisol. So remember, Cushing's is the opposite of Addison's. So now we're secreting too much of those hormones. So I wanted to put this in here on purpose because sometimes you'll see Cushing's called I can't say it. Adrenalism, that's what I'm trying to say.
Yeah.
All right, Cushing's syndrome is often attributed to what? So remember, if you take steroids for, like, say your, I don't know, COPD or something, and you take them on a regular basis for a long period of time, you could make yourself get Cushing's. So prolonged use of steroid therapy. Okay, so after someone gets an adrenalectomy, the nurse should monitor the patient for what immediate post-op complications. Okay, so it's blood pressure changes. So remember, your adrenal glands are the glands that we're dealing with when we talk about Addison's and Cushing's. So the adrenal gland, they actually secrete your fight or flight stuff, so your epinephrine, norepinephrine. And so if you get your adrenal gland taken out, there is a slight chance that you would get a secretion of those into your bloodstream as you remove it. So you could see some blood pressure changes. How does radioactive iodine work? Okay, so it destroys hyperactive thyroid tissue. And then define positive chopstick sign. So this is the facial muscle one, right?
Yeah.
All right, so then I think that, yeah. What electrolyte imbalance is associated with Trousseau sign? So that's what your arm does and your hand does when you pump the
Mhm.
blood pressure cuff. It's positive. It looks like that. Low calcium.
Mhm.
All right, which of the following is an example of a wound healing by secondary intention? Good. So an open burn area. So that would definitely be something that has to fill in on its own. Okay, stage this wound. You just have to look at it and say what it is. Okay, so it's a suspected deep tissue injury. So remember when we were talking about this earlier, we said it looks like a bruise. So that's what that looked like there. So that's what this is.
Mm.
Okay, here's another one for you to stage. Well, this is stage 2. I don't know. This one's kind of a iffy one, I think.
It looks weird. It don't look like it looked like a blister.
Yeah, it looked like a blister to me.
It basically was a giant blister, but they called it a stage 2. All right, I think this next one's better. All right, this is different. So all of the following are signs and symptoms of Cushing's except which one is not a sign of Cushing's? Dry, flaky skin is not a sign. So all the other 3 things are. Okay, what's a normal magnesium range? I think I put a few of those here. What's a normal level for sodium? Okay, 135 to 145. All right, and then which is an example of an autoimmune disease? These are. So MS, rheumatoid, lupus, type 1 diabetes, scleroderma, and psoriasis, all of those are autoimmune. Which type of graft utilizes the client's own skin for wound coverage? This is the autograft.
Mm-hmm.
Okay, what mineral is important for protein synthesis, collagen formation, and promoting wound healing? Zinc. I know that one's kind of hard, but all right. At what CD4 count should an HIV positive patient be placed on their medications? Yeah, so if they're less than 200. All right. I think this is the last one. Addison's patient stops prednisone. She presents to the ED with fatigue, nausea, vomiting, and hypotension. Why? Yes, this is adrenal crisis because they stopped the prednisone. All right, let's see who got it.
Yeah, I'm finally on the board. I'm never on the board, finally.
All right. So anyway, that's all I have for you guys. I hope that helped you a little bit. I'll post this because I recorded it, so you guys could look at it again if you need to. Okay?
So the graph question, you just wanted us to know the different types, right?
Yes. Mhm.
Okay.
Okay.
I also have a question.
Yeah.
So I know, like for the endocrine disorder, what lab test will you look at? Because it's like a lot of them out there. So I'm like, I'm not sure.
Oh, yeah. Here, let's talk about that real fast. There's a specific question that says select all that I don't know. These questions kill me. All right, let me see if I can find it here. It's hard for me to like put it a certain way to you guys on your thing without like telling you what exactly it is, you know? See if I can find it real fast. It's something like you're assessing someone's genetic risk for endocrine disorders. And it says the nurse should ask the client if any relatives have a history of which of the following endocrine disorders. So it's more about genetic risk for them. So which ones have a genetic risk associated with them? So if you wanted to look in your book specifically for this, there's probably like page 1109 and then 1158B. So I don't know if the B means like there's a chart or something associated with it. I'm not sure. You'd have to look and see. Okay.
1109 and what?
1158B. So again, it must have a chart or something, and that's I don't know what the B means.
Okay.
Are you saying for that one we're not really looking at the lab tests to see?
Yeah, the question itself is the nurse is assessing a client's genetic risk for endocrine disorders. The nurse should ask the client if any relatives have a history of which of the following endocrine disorders.
Mm-hmm.
Okay, so it's more about like a genetic risk associated with that endocrine disorder.
Okay, thanks.
So probably it's going to be like one of those disorders, like the ZIMS.
Like what?
Like one of those diseases then, if that's what this question is actually asking.
Yeah, I mean, so we talked about a few things that have a
Mhm.
genetic risk. So
Okay.
not everything that is correct on here we talked about though. So you need to definitely look in the book at this because there's certain things that it mentions that we have not talked about.
Yeah. Okay.
Okay. All right, guys, I will see you later in the week. If you need something, just get a hold of me, okay?
Okay.
All right, thank you.
Also, I have a quick question.
Yes.
Okay, so for the drug resistance, right? Because I looked into the book and then it was saying like hand washing was bad, but you were saying that the hand washing doesn't apply in this situation. I just wanted to make sure of that question.
Which one?
It says resistance, the antimicrobial resistance or something. Give me a second. Let me look at that particular question. Yeah, it says, I think, yeah, the antibiotic resistance. Because the last time you were talking about it, you said hand washing what doesn't apply in that situation. But then the book was talking about hand washing in there, so I was kind of confused.
I'm just trying to find it. Hold on. Yeah, so this is saying the nurse is providing an educational conference about antimicrobial resistant organisms. So which of the following information should the nurse include in the conference? So yeah, it's the answer is not hand washing. So you need to take a look at that. So this is on page 216, 217 in your book. Okay, we good?
Mm-hmm.
All right, guys, I will see you later. Thanks.
Okay.
Thank you. Bye.